Good afternoon, or good noon, as might be the case in Alaska right now. We're very pleased to be presenting this program on the management of concussion and post-concussion syndrome for you, and we'll look forward very much to taking your questions at the end of the presentation. In your chat and email will be the directions and details about getting your accreditation for this hour's course. We have some disclosures, but no conflicts. And with that, I think we're ready to roll. I think all of you know that concussion is a type of traumatic brain injury that usually is caused by a hit to the head, but doesn't have to be. The head can simply be put in motion inertially by a blow to some other part of the body that snaps the head back or snaps the head forward. The symptoms of concussion, most of the time, are going to clear up within a matter of a few weeks. But about 30% of the time, the symptoms may be prolonged. And when they're prolonged beyond 1 month, we normally use that time frame now for post-concussion syndrome, or what others more recently have been referring to as persistent post-concussion symptoms, because some people still argue a little bit about what is exactly the syndrome of post-concussion syndrome. Normally, a neuron receives an impulse from an adjacent nerve cell, and then that impulse travels down the axon to be releasing neurotransmitters at the end of the axon, which then activate the next neuron and transmit the message. And that's kind of how one nerve cell talks to another cell, and how billions of nerve cells talk to each other within a brain. When there's an injury, what happens is a neurometabolic cascade of change happens. The potassium ions and the sodium ions that are normally inside neurons and inside the axons egress out and get into the extracellular space. And the ions that are in the extracellular space, mostly calcium ions, go into the neurons. And when that happens, there's essentially a metabolic crisis, and transmission of impulses stops. In addition to that, there's a chaotic release of neurotransmitters from the end of the axon. So essentially, the cell is alive, the axon is intact in most cases, but the transmission of the impulses cease, and so essentially there's a dysfunction and the nerve cells aren't working. That's the situation virtually in all concussions. But in many concussions, in addition to this neuronal metabolic cascade of injury, there also is structural injury. And there's actually tearing of axons in many cases and shearing of nerve fibers in other cases. So virtually every case has a neurometabolic cascade of change, and some cases of concussion also have structural damage as well. This metabolic dysfunction may last hours, days, or weeks, but normally it is over within a week or so. And once the ions have gone back inside the nerve cell, the potassium, the sodium as it needs to be, once the neurotransmitters are back on the end of the nerve ending, then the cell can function again. And this is just simply showing a cell that now has the proper ions within the cell, the neurotransmitters back on the end of the axon, and the cell is functional again, as it normally is in about 70 to 80% of the cases within hours or at least a week or two of the injury. I think you're all well aware of the fact that the great majority of concussions, especially athletic concussions, do not lead to loss of consciousness. More than 90% of athletic concussions do not have loss of consciousness. If we're talking about high-speed motor vehicle accidents or falls from a height, then unconsciousness is more common. And we've already mentioned you don't have to hit your head to have a concussion. You simply accelerate the head from a blow to some other part of the body. Helmets may slightly reduce your risk for concussion, but they certainly don't prevent it. And they don't prevent at all the subconcussive hits that also can lead to brain injury if they accumulate enough. Concussion symptoms most often are present right away. They may increase in number and severity over time, but sometimes concussions happen and individuals are not aware of symptoms right away, but rather hours later that day, later that night, they're aware of the headache, they're aware of the brain fog, they're aware of the confusion. Most of you are probably aware that young athletes are more susceptible to concussion and they take longer to recover. Women, on the other hand, have a higher number of concussions in the same sports that they compete in as men, such as soccer and ice hockey and lacrosse. On routine CAT scanning and MRI scanning, the scans will be normal with concussion because concussion, even when there is a structural injury, will be microscopic in its origin. And it's not macroscopic. And so these imaging studies, the routine MRI or CAT scan, are going to be negative. We think of concussions as having domains or baskets of symptoms. There are cognitive symptoms such as feeling in a fog, being confused, having issues with concentration or memory, feeling mentally slowed down. There are a number of physical or somatic symptoms like headache, nausea, vomiting, sensitivity to light, noise, neck pain, ringing in the ears. There are vestibular ocular symptoms, difficulty with balance, blurred vision, double vision, or dizziness. And there are sleep symptoms. Most often, people sleep more right after a concussion, and then a week or two later may have difficulty with falling asleep. And along with that, being drowsy, fatigued as well. And with concussion, there are also emotional symptoms, such as depression or sadness, anxiety, irritability, short fuse, and feeling more emotional. The Centers for Disease Control have management guidelines for concussion and traumatic brain injury in children, and other guidelines for concussion management have been put out as well by the American Academy of Pediatrics, as well as the consensus statements from the international concussion and sport conferences held in Europe, most recently in Amsterdam just 2 weeks ago. But prior to that, it was the Berlin conference in 2016. Technically, post-concussion syndrome has an ICD-10 code, and there also is another published guideline for concussion and post-concussion syndrome as well. But practically speaking, clinicians recognize post-concussion syndrome or persistent post-concussion symptoms as symptoms that are lasting beyond a month. In other words, the typical symptoms of concussion that we just went through that fall into those domains, if they last beyond 30 days, we normally refer to that as persistent post-concussion symptoms or post-concussion syndrome. Those two names are really interchangeable. When evaluating somebody for a concussion, the assessment for most first concussions and first visit with a patient will be similar to other first patient visits and take upwards of an hour to be thorough. And when you're inquiring about the concussion that somebody's just had, you want to know, of course, when it happened. You want to know the immediate symptoms they had, whether there was any loss of consciousness, whether there was any anterograde amnesia after the concussion, or retrograde amnesia for things that happened before the concussion. In medical follow-up, if there has been any assessment, you'll want to have access to that, those records whenever possible. I think it's important also to realize that with concussion, there are things that rather routinely will exacerbate symptoms, such as cognitive activity. So for our scholar individuals, schoolwork will often aggravate symptoms. Physical exercise, if done to extreme, will almost always aggravate. Sleep or lack thereof may trigger symptoms. Computer screens, your iPhone screen, almost always exacerbate symptoms right after a concussion, and time in front of screens, including television, should be limited. When evaluating someone for a concussion, not only are you going to want to know how many previous concussions they've had and how long those previous concussions took to clear and what the symptoms were as best someone can tell you, but you're also going to want to know about whether your patient has red flag conditions that kind of make you think, wow, this person is probably at risk to have a prolonged recovery from their concussion. And these are the conditions that are associated with a prolonged recovery. Not in every case, but certainly more often than not. If your patient has a previous history of psychiatric issues, depression, anxiety, panic attacks, a previous history of migraine headaches, a previous history of a learning disability, ADD, ADHD, or dyslexia or other learning problem, a seizure disorder or other psychiatric disorders, these are all red flag situations where you're kind of alerted that this patient very likely is going to have a prolonged recovery. You're also going to want to inquire about whether the individual is on any medications, as you would anyway, and whether the individual has any allergies. The neurologic examination for a concussion is a rather typical neurologic exam, but there are parts of it that are more important because they're more likely to be abnormal following a concussion. The reflexes, the sensory exam, the motor exam are almost always normal after a concussion. But the cognitive examination is a pretty sensitive area and is often abnormal, as is ocular testing of eye movements. So visual tracking with smooth pursuits and saccades is a valuable tool to use to see if someone has issues following a concussion. And this is particularly important if someone's complaining of visual symptoms, such as blurred vision or double vision, or screens being blurred for them. Also, part of that ocular exam should be detailing what is the near point of convergence. As somebody brings an object toward their nose, they should be able to get within 5 centimeters and without seeing that object as double. And both vestibular ocular reflex and vision motion sensitivity testing are also part of the eye tracking triad that is useful in determining whether one has eye findings following the concussion. It's also true that following a concussion, especially acutely in the first 72 hours, but it can last longer, balance is often off, and a modified best testing where you're doing a Romberg with your feet together, and then you're doing a tandem stance for 20 seconds with one foot in front of the other, eyes open, eyes closed, hands on your hip, and also single leg stance, hands on your hip, eyes open, eyes closed for 20 seconds is very useful. Part of every concussion assessment should be an assessment of neck function in terms of full range of motion of the neck, in terms of whether there's any discomfort with palpation over the greater occipital nerves or the inion or over the spinous processes themselves. Neck injury is not infrequent with concussion and should be looked for. If you assess one and do find evidence of cervical pain or limitation of motion, then part of the therapy for that individual very likely is going to be cervicogenic physical therapy directed toward their neck. This is the symptom checklist that we use and have developed. It breaks the symptoms down into cognitive symptoms, the first 7 you see there. Then the next set of symptoms are physical or somatic symptoms. And then moving over to the right side, the first 4 symptoms are vestibular ocular symptoms. The next set are sleep. And then finally, the bottom 4 symptoms on the right are emotional symptoms. And for each of those domains, whether it be cognitive or whether it be somatic, vestibular, ocular, sleep, so on, we derive how many symptoms there are, the number, and then we also look at what the scoring is, whether they're 1 through 6, and we put a score for each. And so we can tell which domain of symptoms is most symptomatic for somebody, and then we can direct therapies to those domains of symptoms, especially when the neurologic exam will find very often abnormalities in the same areas as the domains of symptoms are abnormal. And this is simply the same checklist, but blown up, showing you how each of the domains are going to have their own individual scoring done, and as well as scoring overall for all the domains and the entire symptom score. There are clinical tools that are out there that you might use for evaluating concussion. The SCAT, I should caution you, is very good on the sideline. Its accuracy falls off quite rapidly, and beyond 72 hours, it's not such a good tool in the office. The graded symptom checklist is, of course, good, no matter whether you're seeing somebody acutely or down the road a little bit. The McGill abbreviated concussion evaluation is a popular one, as is the Rivermead. The one that's not on this slide that will be coming out of the Amsterdam Concussion and Sport Group meeting just concluded and is not yet therefore published. It's what is called the SCOT. It's a modified SCAT for office use. And so it is more robust than the SCAT and involves a much more detailed visual assessment than is in the SCAT. And it's designed to be used beyond 72 hours, but actually can be used anytime that you see someone in the office. The SCAT is still for the sideline assessment of concussion, but the SCOT is the one that you will be using in your office in the future, I would suspect. This is simply the balance testing that we talked about, the modified BESS involving Romberg, involving tandem stance, single leg stance. Looking for ataxia with heel-toe walking, eyes open and eyes closed is a useful maneuver that's used by many. If you have $100,000 at your disposal, the sensory organization test is a platform that kind of moves one around and tries to push you off balance. And you try to stand on this, and you can have computers determine how much sway you have and whether it's excessive. Not exactly a test that we use in our office or our clinic. There are tests that can be used on computer to do your cognitive assessment. It's not necessary to use these tests. The cognitive assessment can simply be done with paper and pencil very nicely. But if you want to do it on computer, there are programs by Impact Cogstate from down under Australia, Headminder, and ANAM, the US Army computerized cognitive assessment tests that can be used. I think they're useful. I don't think they're necessary to be used. I think cognitive tests can be applied without computerized testing. A few years back, a conference was held, financed by the National Football League at the University of Pittsburgh, and a lot of us in the concussion research and education field were brought together to discuss therapies and active management of concussion. In other words, in the distant past, concussion was more or less just managed with physical and cognitive rest. And we now know that that does not enhance recovery from concussion. And this conference was devoted to the various therapies that definitely do enhance recovery from concussion. We'll go through that in a minute. But it also pointed out very strongly that physical activity kind of universally is effective in helping most people get over a concussion more rapidly. And I'll have a bit more to say about that. So evaluating and treating concussion, especially treating, is really a team effort. It involves a concussion specialist who might be a neurosurgeon, might be a primary care physician, might be somebody from any background, but then depending upon the constellation of symptoms and signs the individual has, we may be involving a therapist to work on their cervical spine. We may be involving cognitive individuals if they have cognitive symptoms, eye tracking experts if they have ocular symptoms. For people with persistent post-concussion symptoms beyond 3 or 4 months, we'll probably think about an endocrine assessment to be certain they don't have any problems with their pituitary gland. For those that have prolonged emotional difficulties, a psychologist or psychiatrist could be a member of the team. For those that have tinnitus and issues with hearing and dizziness, ENT assessment. So there is quite a cadre of individuals that make up the concussion assessment team. The initial treatment for concussion is rest, the first 24 to 48 hours, and thereafter it's making adjustments and getting people back to the activities that they would normally be doing, whether it be work or school or just being at home, as quickly as possible, and that we can do it at a level that doesn't make symptoms worse. And we also want to keep them while they're recovering away from activities where they may have some head contact and could further injure themselves. We also want to limit screens, whether it be electronic or not, in the initial days after concussion. And then when we do start to liberalize, we always let people get back at a duration and a focus level that doesn't exacerbate symptoms. So the initial treatment for concussion over the first 24 to 48 hours is initially rest, and thereafter it's exercise for everybody, but at a level that doesn't exacerbate symptoms. And even if a very low level of walking exacerbates symptoms, then we shut them down from that too. But generally people can get back to the activities of daily living quite rapidly after a concussion. And we use progressive exercise to pretty much treat all the domains of concussion symptoms in addition to the specific treatments for the domain of symptoms. With regard to the aerobic exercise after concussion, there are steps that we normally go through. And with regard to the rehab of concussion, if somebody's symptoms are lasting beyond a month or two and they're not clearing, they've stalled out, then the balance and vestibular symptoms are treated with vestibular therapy. The neck pain and headaches are treated with cervicogenic headache treatment with our physical therapist. Return to activity protocols are utilized for virtually everybody. Those with eye tracking difficulties will be referred to occupational therapy for eye therapy, eye tracking therapy. Cognitive therapy with our speech therapist is very useful for those with cognitive dysfunction and cognitive symptoms and difficulty with focus and attention. With regard to the graduated return to school strategy, first it's just activities of daily living at home, and we gradually increase the screen time very slowly and gradually increase the activities. Return to school is done usually at a reduced level than full-time in the beginning and gradually increased as the individual is able to do it. The most important thing is to have your level of increase, time and effort and intensity be very gradual and under the radar of aggravating symptoms. If we aggravate symptoms, we want to pull back. In addition to the return to school activities, return to sport activities also are progressive and gradual. Initially, it's light aerobic exercises, moving on to sport-specific drills, as long as it can be done without aggravating symptoms, and then non-contact sport drills, finally, full practice, and lastly, essentially, full contact in full practice. If one takes hits in practice and symptoms come back, then they're not cleared to go back to participate in gameplay. Normally, we stretch these gradual return to play steps out over a 24-hour period, so you don't normally progress from step 1 to step 3 in one day, but rather over 3 days. Most people will be able to get back to work, depending upon what study you want to cite. 73 to 80% of people will be back at their normal occupation within 1 year. That's still a fairly significant percentage, so that's not back at work in 1 year, which is a pretty long period of time. Whereas physical and cognitive rest is important in the first 24 or 48 hours, we do start exercise now quite early on, but exercise only at a level that doesn't make symptoms worse. And that varies greatly with different people. It varies greatly depending upon the severity of the concussion. When an individual gets back to work, they often are faced with the fact that fellow workers don't really see an obvious injury and that their symptoms may affect their ability to do their job, and other people may not be knowledgeable about concussions and knowledgeable about the difficulties they're going through. That's one of the problems with concussion, especially somebody returning to the workplace. There are things which, when we see them, again, are kind of red flags that somebody might have a prolonged concussion recovery and might have some difficulty getting back to work. Some of those factors include dizziness, post-traumatic stress over the circumstances around the concussion, a high number of symptoms, and a high severity score. the symptom checklist we showed you had 26 symptoms on it. The closer you get to 26, the more likely someone's not going to get back quickly. The symptom severity score is 156. Everybody had symptoms with a score of 6. Of course, nobody does, but the higher you get, certainly anybody over 100, is at great risk to not get back very quickly. Individuals, as we indicated before, that had pre-existing mental health or psychiatric issues are at risk for getting back not very quickly. If somebody doesn't have a high level of IQ and has a rather low IQ, we think of that as less reserved. We think of that as if you knock that down even lower, that's probably going to take them a little longer to function in the normal range. Whereas somebody with a very high IQ may not be functioning normally for them, but even impaired functions in the normal range and can get back to work. And then obviously, when there are workman's compensation issues or litigation, other things clouding the issue, these are red flags as well, that somebody might not have such a rapid normal recovery. One of the things to think about when somebody's getting back to work is just what is that job? What are the necessary ingredients for that job? Is there risk of re-injury at that job? If somebody is going up a ladder 10 steps or 12 steps up, you probably don't want them doing that while they're recovering from a concussion. And you may let them get back to work, but maybe not go up a ladder more than 1 step or 2 steps. Also, when you're returning somebody to work, if they're unable to return to work, that's when you want to refer for appropriate therapies. If somebody has cognitive therapies, it's cognitive therapy. If it's obviously balance and vestibular issue, it's in that neighborhood that you're going to be making referral. So you refer your patients to the therapies where they have domains of symptoms and or have physical findings on your neurologic examination. If the therapies themselves are not adequately successful in allowing one to recover, then as a fallback, as an extra, we use pharmacy. But we don't use pharmacy first. We use pharmacy only after the therapies have not been useful. For the cognitive therapies, for the people with cognitive symptoms, issues with concentration, issues with memory, issues with focus, we use primarily the methylphenidate group of medications. The same medications that are used, by the way, with ADD or ADHD. And some of those medicines involved are on the screen here: Ritalin, Adderall, Concerta, Strattera, Vyvanse. If the methylphenidate medications are not working, then amantadine can be tried. It works a different way and sometimes is successful. The Aricept and the Mendia are normally medications that aren't used with post-concussion syndrome symptoms, but are rather used in individuals with dementia-like symptoms. If an individual is showing explosive behavior, short fuse, agitation, anxiety, then Lexapro is often useful in those that are over the age of 12. Zoloft can be used as well as Depakote. For individuals with pseudobulbar symptoms, inappropriate laughing and crying, seeing a situation which normally would be sad and they break out laughing, and vice versa, Nudexta can be very useful for many individuals. Depression, the medicines we use are the same ones that are used for depression, not associated with concussion. Lexapro, again, in individuals over 12 is useful in many. Sertraline or Zoloft is a kind of a mainstay. Cymbalta, Prozac all are widely used in depression. People who have difficulties with sleep, falling asleep especially, most individuals that have sleep problems with concussion, it's going to be falling asleep that's the major issue, not so much staying asleep once they get to sleep, although a small number will have that problem as well. Melatonin is one that we basically have everybody try, 3 to 6 to 10 milligrams of it. It's over the counter. You don't need to prescribe it for your patient. And it really is naturally occurring in the body and therefore really has no harmful effects for almost everyone. The sleep prescription medications that you see here, trazodone, Ambien, risperidone, Nuedexta, all can be used in individuals with protracted getting to sleep problems, but it needs to be very well understood that it's very easy to get people addicted to these medicines. And so it's best if they're not taken every night, but probably on an alternate night or every third night basis. And you want to get people off these medicines as soon as you can, whenever possible. For the physical symptoms, the somatic symptoms, headache being the most common of them all, amitriptyline is very useful at doses that it would not normally be prescribed for people with depression. Very low doses, 25 milligrams or less. Sometimes it'll be doubled. The advantage of amitriptyline is that it helps most people get to sleep. So if you have the combination of headache and trouble falling asleep, amitriptyline is a very nice medication that corrects both of those conditions in many people, if not most. Neurontin is another medicine that's widely used for headache. And if those medicines are not working, then often others that are in the psychiatric realm will be tried that also may have quite good efficacy for a given individual. And those include the Lexapro we talked about before, Zoloft, Inderal, propranolol, which is really a blood pressure medication, a heart medication, but is very useful in many cases of headache following a concussion. Well, I guess that's how you get your accreditation, and the details are in the chat. And I guess that's it. So I'm very happy to spend the rest of the hour answering your questions, and I hope that a number of them have come into the chat.
Thank you, Dr. Cantu. This is Mike from the Concussion Legacy Foundation. Can you hear me?
I hear you loud and clear.
Thank you for a great presentation. We did get some questions in our Q&A, so I was just going to read a few of those off. Starting with, can you explain second impact syndrome and other risks of returning to play from concussion too early?
That's a wonderful question. I thank whoever put it in the chat very much, because it certainly is something we should talk about. Second impact syndrome is someone who still has concussion symptoms, who then takes another hit to the head, usually, or has the head accelerated by an indirect hit and inertially loading it. Most of the time, it's another hit to the head. What happens when you have already injured your brain and you're symptomatic and you haven't recovered from it, and then you take another hit to the head, is rarely, fortunately, the second impact syndrome, and it occurs most often in adolescence. So adults are not immune from it, but it's the adolescents that are more prone from it. And what happens is there is essentially a dysautoregulation and a wide dilation of your arterial tree. so that at a normal blood pressure, your arteries are now wide open and arterial blood rushes into your brain faster than venous blood can drain out of it. So the brain becomes congested, essentially, with blood. And this raises intracranial pressure dramatically, very rapidly, and often leads to brain herniation. And the brain herniation is what causes death in a very high percentage of cases of second impact syndrome. There can be mild cases, but unfortunately, more than 50% of the time, there's death. And even when there isn't death, there's usually prolonged morbidity from the effects of brain herniation. Now, that's what happens not commonly, thank goodness, but can happen, and should be a reason nobody, especially a youth, is ever allowed to play symptomatic. On the other hand, what happens most commonly when you have not fully recovered from a concussion, and then you take a second blow to the head, or worse yet, receive another blow to the head that causes another concussion, is that the original concussion symptoms not only are greatly worsened, but other concussion symptoms often occur, and almost uniformly, the arc of recovery is greatly lengthened out, so that somebody that might have recovered from that concussion properly managed in a day or two or a week or two now goes on to months and months of post-concussion symptoms. So you definitely don't want to allow anybody to take second traumas to the head while still symptomatic from the first concussion.
Thank you. A part question here, Dr. Cantu. When should you start referring patients out to other care providers? Is telehealth a good option for remote patients that may not be able to travel to multiple providers?
A good question, a very good question. And I think it will depend a little bit on the comfort level of the primary care physician or pediatrician that's initially managing the concussion patient. Because most people are going to recover from their concussion within a week or two, children maybe stretch that out to a month, you might want to wait at least a few weeks, or in children, maybe upwards of a month before you make that referral, as long as someone's getting better and their symptoms aren't getting worse. If their symptoms are getting worse, then obviously you might make that referral sooner. So that I think it, again, is a little bit dependent on your comfort level and in managing concussions. But when the symptoms get beyond where they normally would clear up, that's when therapies are going to really be a big help. You also, seeing someone, can start the exercise therapy yourself at 48 hours. And for most, that's just going to be walking at a pace that doesn't exacerbate symptoms, but you can be taking an active hand in providing therapy for your patients.
Thank you, Dr. Cantu. A related question, any recommendations for online/telemedicine resources for patients with PCS who live in remote locations? Going on to say, this can be challenging, obviously, with screens triggering PCS symptoms, but for patients who live in rural areas, we have extremely limited resources for multi-specialty/team-based concussion care.
Yes, obviously, you can't do a thorough neurologic examination by telehealth. You can do a cognitive exam orally by asking them to do numbers and remember words and give them back to you at a later date, do mathematical problems, so on. But you can't obviously do a very good balance assessment. You can't do a very good eye tracking assessment. But if the option is not having a specialist be able to see one at all, or just seeing them by telehealth, I would strongly favor telehealth for those that are having persistent symptoms. Certainly, as I said, the exam has parts that will be lacking, but overall, the guidance, I think, is far more important that would be coming from somebody with expertise in concussion management. So I would very much support the use of telehealth if it's difficult to be seen in person.
Thank you, Dr. Cantu. This question about rehab therapy options. What should we tell PCS patients whose symptoms become significantly worse with PT, OT, vision, speech-language pathology, weeks and months after injury?
Well, first of all, the therapist who is administering the therapy should be very sensitive to anybody whose symptoms are aggravated, and they should be modifying the way they're delivering the therapy so that it's delivered in a way that doesn't aggravate symptoms or stop the therapy completely. The one exception being vestibular therapy, which we do let people be slightly exacerbated during the therapy itself, but by the next day, day after, they should feel better. With regard to vestibular therapy, there is a certain amount of desensitization of the brain going on when those symptoms are exacerbated during the active therapy. But we don't let them exacerbate extremely. We normally use a symptom score scale of 1 to 10, and we let somebody worsen by a couple of points, going from a 3 to a 5, a 6 to an 8, an 8 to a 10, but we don't let them go like from a 3 to a 7. And the therapist should be knowledgeable that if they're exacerbating symptoms, they need to either pull back on the intensity with which they're giving the therapy, and if that doesn't work, they may need to defer that therapy to a point in time when it can be delivered without exacerbating symptoms.
Thank you, Dr. Cantu. This question about retirement, how many concussions is too many? Is there a specific number that we should be telling athletes or professionals to retire if they sustain that many?
That's a wonderful question. And it doesn't have a perfect evidence-based answer. Generally speaking, there is no number. There are some people that have said 3 and you're out and things like that. But no, concussions are not created equal. Somebody that's had a concussion and took 1.5 years to recover from it, you might think that they might retire from that sport just from that one concussion. On the other hand, somebody who had 5 or 10 concussions and they recovered every time within hours or a few days, we'd probably let that person go back after an appropriate period of time. So there's not a magic number, but we do count the numbers. We do count how close the concussions were together. We worry more when they're in close proximity than when they're years apart. We also worry most about how severe the concussion is, graded by how long the symptoms lasted. As I said before, if the symptoms clear very quickly, we tend to not be as concerned as when somebody's had symptoms that last a very long period of time. What happens with many athletes and guides me in advising individuals when they should retire, at least in my opinion, is that blows to the head that earlier in their career did not produce symptoms at all, now produce concussion symptoms, and the symptoms last a long period of time. So somebody who very early in their career took a number of violent hits to the head without symptoms and is now becoming symptomatic simply because they're getting jostled around a bit and their head is snapped a bit forward or backward, those would be kind of red flags that this individual is now concussion prone and should retire, because they're certainly going to be taking those kinds of hits all the time. Great question.
And next one here, I just want to get this one right. What can we do as providers to educate patients and families in Alaska so that patients are set up for success immediately after injury?
Well, that's a wonderful question, and I'm very, very pleased that somebody wants to do that. Concussion education is huge. The most sensitive evaluation tool that we still have after all this time because none of the biomarkers are ready for prime time yet for a given concussion patient. Fortunately, the blood biomarkers have shown great promise in pooled studies where you group of people with concussions and another group without, and you can tell difference, but you can't tell it from one patient to another. So they're not specific and sensitive enough to be used. The most sensitive thing is still the concussion checklist that we showed you, the different domains of symptoms. And if the athlete doesn't know what those symptoms are, they have no way of recognizing when they're symptomatic from a concussion. So all athletes should be given concussion education, and ideally, even if you're not an athlete, it would be wonderful if your patients had concussion education as well, so that they could recognize what are concussion symptoms, and if they were experiencing them, bring themselves out of whatever activity they're in, and if they stay, bring them to you to be evaluated.
Thank you. One more question here, and last call to groups in our chat and Q&A. If anyone has a question they'd like answered, please submit now. The last one we have is, what resources do you recommend giving to patients and families for education and support after injury?
Well, certainly the Concussion Legacy Foundation website, I think, is wonderful. There are many educational tools about concussion, post-concussion syndrome, CTE, etc. And also the helpline is a very valuable resource, I think, for many in terms of finding somebody with expertise in this field. So one of the resources is certainly the Concussion Legacy Foundation. Another wonderful resource is going on the CDC's website. They also have an extensive amount of information about concussion, concussion symptoms, management, etc.
Thank you. Dr. Cantu, I think that was it for questions from our Q&A and from our chat. We really appreciate your time. And with that, I believe we will wrap things up. Any final thoughts, Dr. Cantu?
Just thanks to you for moving the slides along, because I couldn't do it.
No problem at all. Thank you to everyone joining us.